Hi everyone, so today I'm going to talk about sickle cell disease. And what sickle cell disease is a type of hemoglobinopathy. And this word tells you a lot. So pathy means uh, an abnormality, and this involves the hemoglobin. So in sickle cell disease, what the abnormality is there's a mutation in one of the amino acids in the beta globin chain. So in adults, in red blood cells, it contains the presence of hemoglobin, and in adult hemoglobin, it tends to be largely hemoglobin A, which comprises of two alpha chains and two beta chains. In sickle cell anemia, however, there's a production of the hemoglobin S type of globin chain, and that is a mutation in the beta globin chain, like we mentioned before, um, and that results in the manifestation of sickle cell disease. So before we proceed further, I'd just like to explain what the difference between sickle cell disease and sickle cell trait is. So in sickle cell disease, um, this condition is a autosomal recessive condition, and what that means is that you need two of the mutated genes to be present for the individual to have um, the disease. So two copies of it. And in sickle cell disease, there's the presence of two gene mutations. So they are homozygote. And homozygote just basically means there are two of the hemoglobin S gene mutations. And in the sickle cell trait, there's only one of it. So it's a heterozygous. And it's also important to mention for sickle cell trait, it confers some form of selective advantage. So the reason for that is that in certain populations uh, in Africa, where malaria is more prevalent, um, the parasite malaria tends to have one of its life cycle in the red blood cell. And when patients have sickle cell disease, which we'll explore more later, it'll be harder for the parasite to grow in these sickled looking red blood cells, and it's harder for them to actually grow successfully within the host. Therefore, they are less likely to have severe symptoms, and therefore they are more likely to survive to reproductive age. As a result, this gene mutation is kind of preserved in certain population groups. So I'll just talk about which groups are more prevalent. So the West Africans tend to be uh, tend to have this gene, um, and 1 in 12 African Americans carry the trait, and about 1 in 500 carry the disease. So in any questions, if you see African Americans or African patients, do suspect sickle cell disease or sickle cell anemia. So I'll just go on to explain what the pathophysiology is. So in this condition, there is a mutation in the gene, a single mutation, base mutation, and that changes one of the bases from A to T, and that essentially replaces one of the codon, and the codon codes for a different amino acid. And originally it codes for the glutamic acid, and then it changes into the valine amino acid after the mutation occurs. So glutamic acid is a hydrophilic and a water-soluble amino acid, whereas valine is a hydrophobic. And that's when all the symptoms of sickle cell anemia can arise from. So because it is hydrophobic, it's a lot less soluble, and it tends to precipitate out under condition of low oxygen tension, and it can form long fiber polymers, long fibers of polymers, and it can precipitate out due to low solubility as well. And as a result of this precipitation, the red blood cell changes shape into a very sickled appearance. So the name comes from the sickle, which looks like this. Pardon my bad drawing, but the red blood cells eventually look sickled and have a very sickled appearance. And these sickled red blood cells, they are different from the normal shape of the red blood cells, which is meant to be biconcave and also disc-like. So it can fit relatively nicely through the small blood vessels, including the arterioles and the venules. However, for the sickled red blood cell, it tends to get lodged within tight junctions, and it can actually cause occlusion, which we will talk more about later, and that can result in infarction of certain organs. That means less oxygen supply to certain tissues, and the tissue can eventually become ischemic and may necrose as a result. And it's very important to know this pathophysiology of what we have discussed, because it can explain many of the symptoms and clinical manifestations of sickle cell anemia by simply understanding this. So in terms of clinical manifestations, generally there could be a severe hemolytic anemia with the presence of crises. So crisis, and I explain what crisis sickle cell anemia patients could have. So the anemia itself, it just generally does not cause much of a problem to patients, because the presence of hemoglobin S is actually is actually better able to release oxygen to the tissues, better able to release oxygen as compared to hemoglobin A. So hemoglobin S itself does not cause many anemic symptoms. However, the presence of occlusion results in many of the symptoms that could even cause crises. So that's the main thing to remember about sickle cell anemia, is that it does not generally cause many symptoms of anemia in itself. It's generally mild anemia, but the crisis is the main important thing to note. So I'm going to talk about the crises, which could be vaso-occlusive. So the word vaso means vessels, and occlusive just means blocked. So the symptoms arises when the blood vessels are blocked by the sickled cells. It could either be painful, or it could be classified as visceral. And also it could be aplastic or hemolytic, and we'll explore each of these in depth. So in terms of painful crises, patients can it could either be sporadic and unpredictable, so it can happen for no apparent reason, or it could be due to a precipitation of certain conditions. So in certain conditions, like I mentioned before, when there's low oxygen tension, say in higher altitudes, patients could be more likely to develop a sickle cell crisis, higher altitudes. And also in operations, in delivery, when patients are pregnant, and also infections acidosis. So all these places stress on the body, and could also result in low oxygen tension. Dehydration can also cause crisis as well. So it's important to bear all these precipitations in mind, because you could advise patients to avoid all this. So it's important to remember these precipitations. Any and these are due to infarcts, like I mentioned before, due to occlusion leading to organ ischemia. The bones could also be affected as well, in particular the hips, the shoulders, and the vertebrae could all be affected. And it could also lead to this thing called the hand-foot syndrome. And the hand basically looks like a sausage. It becomes very inflamed and very painful and swollen of the digits, painful and swollen. And it's usually the first manifestation of this disease, and it could result in digits of different length, of varying length. It could also affect the visceral organs as well. So one of the most common organs that's affected is the spleen. When the spleen microvessels are being occluded, it could actually result in infarction of the spleen. And if not treated rapidly, it could result in fibrosis, and eventually what we call autosplenectomy. So the word auto means self, and splenectomy means removal. So when the spleen has no more function left, essentially we are is akin to removing the spleen. And this is what we call a splenic sequestration, and sequestration means to hide. So the sickled red blood cells tends to get taken up by the spleen, and this can occur in such a high amounts that the volume of blood decrease, and it could actually result in shock. So this is a medical emergency, and it's important to recognize it early for sickle cell anemia patients. Also, another issue, another organ that could be affected is the lungs, and this could result in the acute sickle chest syndrome, and it's one of the most common cause of death in both children and adults. And the similar pathology as well, it can cause infarcts of the pulmonary vessels, and that will manifest either as shortness of breath or dyspnea, a decreased arterial PaO2, chest pain could be seen as well. So sometimes this can be precipitated by a lung infection, and it's often very hard to tell this from pneumonia. So oftentimes patients are initiated on antibiotics empirically, and also you want to give them analgesia, because it's a very painful condition. In chest pain can occur, oxygen, and you can also give them exchange transfusion. So what this is you're removing small amounts of the patient's blood and replacing it with a healthy donor's blood, and that will remove the sickle cells and replace it with normal red blood cells, and that will help with this acute sickle chest syndrome. Also, other organs that could be affected. So we looked at the spleen, we look at the lungs. Also, other organs could involve the male genitals, and that can result in this thing called priapism. And that is due to an occlusion of the vessels in the penis, and that leads to painful erections that last for more than 4 hours, and that is also a medical emergency as well. The liver and also the gallbladder could be affected, um, as well as the kidneys. Um, in the kidneys, they could be in particular areas of the kidney, especially the papillae, renal papillae, are very susceptible to infarctions, and that could result in papillary necrosis. So it's important to bear in mind all these organ complications, um, and to educate your patients about these issues as well. So we'll move on to talk about the aplastic crisis. An aplastic crisis generally occurs when um, the bone marrow does not produce the components, so the blood components including red blood cells, platelets, and white blood cells, and that's often precipitated by infections of the parvovirus. It's important to remember this virus, and also from folate deficiency. As you know, folate is an important building block of DNA, and that could account for the aplastic crisis. Um, in this aplastic crisis is you can identify it by a sudden decrease in hemoglobin levels and also reticulocytes, which are earlier forms of red blood cells. And to treat this, you would do a blood transfusion. Also, hemolytic crisis could occur as well. And basically, because like I mentioned before, the sickle cells are quite fragile and they're more prone to hemolysis. You could see that there's an increased rate of hemolysis, and that could release heme into the blood, which is removed by heptoglobin. So you can measure this clinically by a decrease in heptoglobin levels, and this would manifest as a intravascular hemolysis. Now, another important organ that could be damaged is the brain. As you know, the brain is heavily vascularized, and also the spinal cord as well. So when infarctions occur in either of these organs, it could result in strokes, and is a medical emergency, and up to 1/3 of children would have a silent cerebral infarction by the age of 6 years old. So this is one of the medical emergencies to be wary of, and this can be prevented by regular blood transfusions. And also the use of a particular medication called hydroxyurea, or it's also known as hydroxycarbamide in the United States. And what this does is will increase hemoglobin F production, and because hemoglobin F comprises of two alpha chains as well as two gamma chains, this could help to supplement the decreased oxygen delivery to tissues and reduce the risk of organ ischemia. So another thing to mention is that ulcers of lower legs can be quite common as well. And once again, it's due to the underlying pathophysiology of infarctions as well. And also pulmonary hypertension could occur as well. And these are complications to bear in mind. And what I have here is I've created a mnemonic, or I found a mnemonic online. And this is given by the mnemonic Sickle. And the S stands for strokes, swelling of the hands, so dactylitis, and feet as well, and also spleen issues. So splenic sequestration. Infections also can occur. So when the spleen is not working well, there could be more chances of encapsulated organisms, and other types of infections could increase as well. So in particular, the Haemophilus, Streptococcus, as well as Neisseria, these three organisms are the ones to bear in mind. Crisis can also occur. So like we mentioned before, the splenic sequestration, also chronic hemolysis, and also it could also lead to pain crises as well, painful crises. K stands for kidney. Like I mentioned before, the renal papilla could be affected, resulting in papillary necrosis, liver disease, as well as lung issues, and also erection, which is prolonged, and we call that priapism, if you remember. And also, the one that I didn't mention was the eye, and it could cause retinopathy as well. So because the eye is also susceptible to infarctions, I should mention here that patients could also have eye complications and visual complications as well, retinopathy. Yep. So this mnemonic sickle is one to really bear in mind, and it really reminds you of the types of crises that could happen for sickle cell anemia patients. So we want to talk about the investigations. So in terms of investigations, you could do a lab test, laboratory test, and you would find that the hemoglobin levels is generally about 60 to 90 grams per liter. With or without symptoms of anemia, like I mentioned before, it's actually a mild form of anemia. And it's also important and worthy to note that for HBS, because um, beta globin chains are not produced until the infant is about 3 to 6 months old. So you will not see clinical manifestations of sickle cell disease until about 3 to 6 months old, when the body starts to decrease its production of hemoglobin F, which you mentioned before was 2 alpha and 2 gamma globin subunits, and it starts to increase the production of hemoglobin A. But because there's a defect in the beta globin, you start to increase the production of hemoglobin S, and that's when the symptoms start to arise. So it's important to note the timeline of this condition. In addition to that, you can also see sickled cells. So like I mentioned before, the crescent looking cells, red blood cells in particular, and also presence of target cells. And I'll mention and explain what target cells are in a separate video. Also, you could do certain tests like the bimethasulfite test. And what this test does is basically cause sickling of the red blood cells of the patient, and you could identify a sickle cell disease based on this. However, the true definitive diagnosis would be to perform a hemoglobin electrophoresis. And what this does is it will separate the hemoglobin into various bands. So based on its properties, and it will separate it, and the hemoglobin S will have its own band. So you do a reference or a control lane, and you can identify the presence of hemoglobin S based on this hemoglobin electrophoresis. You would in patients with sickle cell disease, you would see an increased levels of hemoglobin F, because like I mentioned before, hemoglobin F would increase, and help ameliorate some of the tissue ischemia that might be present. And there also might be an increase in hemoglobin A as well, which comprises of 2 alpha chain and 2 delta chain. In sickle cell trait, however, um, you will not see typically an increase in hemoglobin F because the condition is a lot less severe, and um, in general the hemoglobin A will be lesser as well, so less as compared to the sickle cell disease. So in terms of treatment wise, it's important to prevent these sickle cell crises, to avoid those precipitation or precipitants that we have discussed before. You would also give them folic acid to prevent the aplastic anemia, and give them 5 milligrams per week. So as you may be aware, folic acid is one of the key building blocks for DNA synthesis, and it's important when cells divide. And as a result, aplastic anemia, a decrease in folic acid could actually precipitate this condition. Also important for patients to maintain good nutrition and health, and also to educate patients about sickle cell anemia and its associated precipitants. It's also important to manage crisis through giving analgesia, especially for pain, and also give them hydration through oral fluids as well as IV saline if necessary. And also, if patients have infections, to give them antibiotics. And like I mentioned before, the analgesic, so you can give them a non-steroidals and paracetamol as well. Sometimes exchange transfusion may be required, and I've explained before what exchange transfusion is. So essentially, we are replacing the sickled red blood cells with the donor's normal red blood cells. It's also important to manage complications like stroke, and the neurological complications. And the guidelines recommend a hemoglobin S percentage of less than 30% for at least 2 years. So based on these levels, the risk of stroke is actually decreased. It's also important to note, in particular conditions like pregnancy, the risk of a crisis could actually increase, and that's due to possibly lower oxygen levels, and that could result in sickling. So it's important to monitor pregnant patients, and sometimes transfusions may be required as well throughout the pregnancy. Well, in terms of transfusions, there's also risk of iron overload, because in red blood cells it contains a fair amount of iron. So it's important to bear that in mind, and I'll discuss transfusions in a separate lecture as well. You could also give prophylaxis, and the one drug that I mentioned before was hydroxyurea or hydroxycarbamide, and what this does is it increases the production of hemoglobin F, which can help to decrease the symptoms of sickle cell anemia because it improves oxygen delivery. One of the definitive treatments is stem cell transplantation. So we are replacing the patient's stem cells with a donor or an allogenic stem cell, and that is a cure. Is considered curative, and 80% of the patients who have undergone a stem cell transplantation remain disease free, and there's also mortality and complications associated with it, which is about 10%. So you will only really consider stem cell transplantation if the patient's lifespan is severely reduced, and also if their condition is very severe. So I'd just like to talk a little bit more about the sickle cell trait. So in terms of sickle cell trait, it's a very benign condition. You would not see signs of anemia, and also the red blood cells tend to look normal on a blood film, and you will not see the sickling that I mentioned before. So hematuria can actually occur, and it is believed to be due to small infarctions of the renal papillae, and hemoglobin S could vary from 25 to 45% of the total hemoglobin. And similar for sickle cell trait, the precipitants should be avoided as well, those that we discussed before. Now, sickle cell anemia is commonly associated with other forms of hemoglobinopathies. So in particular, hemoglobin C is one that I will mention. Hemoglobin C is particularly common in Western Africa. So you can see the demographics of sickle cell anemia and hemoglobin C can be quite similar. And in hemoglobin C, it's also a position 6 substitution of lysine, of the codon coding for lysine, and it substitutes it into a glutamic acid amino acid coding codon. So this happens also on the beta globin chain. And what's important to note here is form rhomboidal crystals. And these rhomboidal crystals tend to cause the red blood cells to be more fragile, and it can lead to mild hemolysis. And also target cells can form as well. So these target cells are also rhomboidal in shape, and so it's important to note that hemoglobin S and hemoglobin C can occur at the same time, and we call it hemoglobin SC. So this is a heterozygous condition of the sickle cell trait, and also the hemoglobin C disease as well. And when patients present with both, it's a more severe condition. Another commonly associated condition is the beta thalassemia trait in combination with hemoglobin S. So when this happens, the primary phenotype is a sickle cell disease. And I'll discuss more about beta thalassemia in a separate video, and other forms of thalassemia as well. So just to summarize the complications, so we discussed several organs that could be affected. We talked about the lungs, where acute sickle chest syndrome could happen. We also talk about the spleen, where a splenic sequestration could present as well. We also talk about the certain other organs like the skin, again, where leak ulcers can happen, priapism, where painful erections could happen, and also the brain, where strokes can occur, and it's a very important complication to take note of. Also, other organs like the liver and kidneys could also be affected as well as the eyes, where retinopathy could occur. It's also important to note the dactylitis, where microinfarctions of the bone could result in swelling of the digits and very painful digits as well. And this can all be classified as a form of a crisis, in particular a vaso-occlusive crisis. So when the vessels are being blocked and that results in less oxygen being delivered to the tissues, that can cause ischemia as well. And also painful crisis could occur as well. And remember that this tends to be precipitated by certain things like dehydration, high altitudes as well, that could lead to painful crisis. And it tends to be in particular bones like the hip, shoulder, and vertebrae. So that concludes the end of the sickle cell anemia presentation. Thank you for your attention.